All right, good evening, everyone. Thanks for joining. We're really excited to have you here tonight for our first Meet the Expert webinar series for PROstep. We have two amazing faculty tonight, Dr. Sam Ford and Dr. Alastair Younger. Just a few housekeeping things. This is being recorded, so you'll be able to access the webinar afterwards. And then also we're going to kind of insert some Q&As into the session as we go. If you have any questions or want to chat with us, you can use both the Q&A and the chat feature. And I'm going to hand it off to our faculty. All right, Dr. Ford and Dr. Younger, you're all set.
Great, thank you. Sam,
thanks for joining us tonight. Dr. Younger and I are at different stages of practices and different stages of adopting MIS techniques, but both really see their value, and we want to demonstrate that to y'all tonight. So we have a disclaimer, of course. The views and opinions of the product experiences discussed in this presentation are those of the presenting surgeons that do not necessarily reflect the views and opinions of Stryker, etc. Dr. Younger, he's joining us from Vancouver at the Footbridge Clinic. He has an academic affiliation with the University of British Columbia. He's won 3 Roger Mann Awards, 3 more than me. And he's really an innovator in this space. And then I'm in Charlotte at North Carolina, teaching residents and fellows. And really, this has been a game changer for me in my early practice. So what do we want to discuss? We want tonight to be an open forum because adoption of minimally invasive techniques, we really think, is giving better outcomes to our patients. And it's really improving outcomes. And the learning of minimally invasive techniques needs to be personalized. You can do it in fellowship, but you also have to do it on your own, especially if you want to stay on the advanced edge. Dr. Younger, do you want to talk about this slide? This is yours.
Yeah, I was just at a Stryker course last weekend, chatting with Errol Bailey and stuff, and we were thinking about, your patient population and your surgical experience. And so if you think about patients, they're either unhappy or they're happy, and it's not so much what you do that makes them happy or unhappy, it's their previous life experience or their experience with surgery. And then as a surgeon, you either do good surgery or you have complications. And when I was doing open surgery, my complication rate was about 10%. And that's actually what drove me to MIS. And also the patients, because they were having open surgery and they often had wound breakdowns and visits to emergency and stuff, my whole aim in life was actually to improve that experience and make them happier. So if we look at this, most of your patients are in this zone. They're 90, they're sort of that group that are, happy and they're doing well. And so that's 90% of your patients. And then you've got about, 9% who are unhappy, but they have good surgery. And, and then there's the 9% who have a complication like a wound breakdown, but they're a happy patient and they're okay. The patient you really got to worry about is that 1% who are unhappy and they have a complication. Now, if we go to the next slide, we can see that if you do MIS, you're going to reduce your number of patients that are unhappy, and you're going to reduce your complication rate. Your wound complication rate will come down. Your fusion rate, at least from what we experienced in the percutaneous lapidus, will go up. And obviously, it means you got to learn how to do this well. But you're going to reduce your unhappy patient. Your unhappy patient with complications is going to go down by 1/4. So that's what drove me to MIS. And there's the real sort of drive to learn. So anyway, I just wanted to sort of share that because if I was still doing open surgery, I'd probably be doing less surgery at this stage in my career. Instead, I'm doing more and more because I have something that I can get a better result with. So back to you, Sam.
Well, I know how I started. I can tell that story. It's more of a modern story of how I started with keyhole or percutaneous surgery. But how did you start? When did you start?
Well, I started back in 1998, and my patient population here, I started off in a province that had basically 2 foot and ankle surgeons. And we had population of 4 million people at that time. And many of my patients were remote, many had bad pathology. And I started off doing all the stuff I did in fellowship, and I got all these wound complications. And so I started doing arthroscopy. And so, I was fairly soon adopted arthroscopic ankle fusion, and then started doing lectures for Anna. And they asked me to do other things like, talk about percutaneous fracture surgery and other fusions and tendoscopy and things. So I rapidly learned the other things, but it was all about avoiding wound complications in patients who are rurally located and simply couldn't tolerate having a wound complication with bad pathology. So that's what drove me. And then I did that until 2014, when I started hearing about what Joe Vanois and David Redfern were doing. And to me, that was just a natural extension to what I was already doing. So actually, my practice had become a blend of both, where I use cartilage burrs and Shannon burrs, wedge burrs, with arthroscopy to try and maximize the outcomes and minimize the invasiveness of surgery. So I would say that 70% of my surgery is now done percutaneous and MIS.
So it started arthroscopic for you.
That's right. Yes.
I think most surgeons that are 5-10 years into practice, that's a shared experience. Arthroscopy is how we got minimally invasive, or nailing fractures, pushing the indications of nailing fractures is how we really got started percutaneous and minimizing wound complications. But what's interesting is I'm at the tail end of sort of an interesting cohort of surgeons who were in residency and fellowship when Redfern and Vanois were coming out, were describing their techniques and their results. And there hadn't been a time period of adaptation among teaching surgeons that had really progressed yet. So I didn't really get the chance to learn it as a trainee. And I think that's one of the biggest things is, how do you, as a surgeon, other than being confident and thinking it's in the patient's best interest to try something, how do you go about that process of deciding to try something new? And how do you consent your patient about that? We have questions about that from the attendees. One of the questions specifically is learning about your surgeon educator thought process. And I think that is intended to be, how do you pick up a new technique, and then how do you teach it?
Yeah. I can give you a few answers to that, because obviously I've been doing that since 1998. And it's quite daunting to go in front of a patient and say, hey, do you mind if I try something new? I haven't done this before. And that would be the absolute best way to get them to say no. And instead, I can't think of a patient actually that said no to me trying an MIS technique. You can go through all these things here, the virtual reality, the observing surgery, cadaver labs. That's what you got to do to get the basic skills. And when you feel you've got a point where you're comfortable and you think you've got the right patient, the right procedure, that's the hardest point in learning. And that's when you've got to take the plunge. And what you need to do is get the consent of that patient. You can't just sort of try and pretend that you're just going to do it and not talk to them. You got to get consent. So what I do is I tell the patient, I've done lots of arthroscopy, and I've done lots of this fusion. So say it's an arthroscopic ankle fusion. I say, look, I've done lots of arthroscopy. I've done lots of ankle fusions. I haven't done an arthroscopic ankle fusion. However, I'd like to try it on you, and it would benefit you because I'm going to reduce the wound complications and improve your outcome. And if I'm struggling in the surgery, I say I'm going to book a little extra time, and if I'm struggling, then I'll bail and I'll do an open operation. You're going to get the same operation you would have got had I not tried. And if you bail, don't feel bad about it, because what you've done is you become a better surgeon. And next time you're going to be that little bit more confident. And unless you kind of push the envelope a little bit each day you operate, unless you learn something yourself and get better at being a surgeon, you won't be able to improve. So you need to get into figuring out how you're going to learn in the environment you're in practice, and improve what you do. when I started doing arthroscopic ankle fusions, people would say, well, you're doing the easy ones. It was actually the opposite. I was doing the hardest ones. I was doing the people where I'd look at them and say, if I can't do this arthroscopic, I can't do an
Can't do
operation.
it. Yeah.
So you get somebody with a horrible soft tissue envelope, you say, the only way I can do this is through the scope. And so I try. And so a lot of the time, what you started off with difficult ones, and then you learn how to do the easier ones, and then your whole ability expanded. So you're able to look after a whole new patient population where with traditional surgery, you might not consider operating on them, like ankle fractures in patients with diabetes, for example. But if you do it through the scope and you use a fibular nail and use percutaneous techniques, you can actually get a really good result with that diabetic ankle fracture. But it's a matter of saying to yourself, okay, I'm going to try this. I'm going to learn how to do the techniques. I'm going to learn how to do the ankle arthroscopy, which actually isn't difficult in a fracture case. And
No.
then tell you why you're going to do it, and then do it. And if you have to bail, well, you have to bail. But every time you try, you become a better surgeon.
I will say that's what's really been interesting is you need to be committed to take more time with the case the first time you're doing it. And I think a lot of mid-career surgeons hesitate at that because they don't want their day to go slower. They want their day to be more efficient. But once you learn the techniques, the cases are often faster than doing it open because you don't have to close. And it saves you time on the back end because you don't have to be looking at an open gaping wound with exposed hardware and bone as often in clinic. So it makes your clinic better. It makes your post-op visits that may be with an advanced practitioner like a PA or an NP in the American system, it makes those visits smoother. There's less suture removal, there's less swelling, there's less pain, there's less phone calls about pain. So it's where do you want to spend your time? At least is to me, and that's why my partners who are hesitant to pick it up, that's what I tell them. For me, virtual reality was not very helpful. Cadaver labs are where I really learned was able to make the most progress. And courses have been a good adjunct to that because you're in a group with like minds and people who are willing to be progressive about a technique change. Is there anything else that any other avenues where you've learned or tried something new? Do you still use any of these techniques now?
Well, I think the virtual reality is good. I think it's actually an excellent starting point. And there's other ways that you can, learn in your own time. A lot of it's a three-dimensional skill. So, I tell my fellows and residents, I'm teaching them how to have feelings because when you're doing open surgery, you can, like a knee replacement, you can see everything. It's right in front of you, but you actually have to have a better three-dimensional knowledge of anatomy than you might actually think in occasion. And then you go to arthroscopic surgery and you're triangulating and you're seeing everything. In this, you're feeling. So you feel the bones and you work out where you are. And then that gives you the ability to work out where the joints are. And so you've got to learn that tactile feeling of being able to operate by your non-dominant hand in 3 dimensions, working out where the bones are, where the joints are, and where your instrument is. And so that's one of the skills you got to learn. And you can learn that, by getting a Dremel. You get the collets. You have to get additional collets from the hardware store, and then use some of your discarded burrs and practice on chicken feet, or you can do a calcaneal osteotomy in a pig leg if you want, and that's stuff that you can pick up in the in the butcher store.
Butcher, yeah. Or you can have your striker reps facilitated for you in a cadaver lab.
Exactly.
That's more expensive.
Sawbones, practicing on sawbones at home, just keep trying different speeds of the burr, different forces, different ways of cutting. Is also something that's excellent to do on your own time, because it's that sort of tactile sense, that sense of three-dimensional orientation of your hands, and that sense of using the burr and the instrument and getting it at the right speed so it actually cuts bone rather than burning bone, is an excellent tool to do it at home in your own time. if you want to get good at this. And then you'll be much more facile when you get back to the operating room.
I think the skill set is different depending on the minimally invasive surgery. I think ankle arthroscopy for a fusion is an arthroscopic skill set and 3D spatial awareness, but you're still floating in a lake, if you will, in 3D space. You need to know how the 30-degree camera works. To me, MICA, minimally invasive bunion, and MIS lapidus both are a little bit more of a nailing skill set for the modern resident, where you're used to nailing tibia and femur fractures and potentially pushing it to plateaus and distal tibias. It is about spatial awareness of where's the bone relative to where you are in space, and how does your brain interpret the X-ray, and if it's a good X-ray, and tell you where to move what you're doing. So I don't know. Anyways, I think that prepared me to better pick it up.
Yeah. People use X-ray too much, because X-ray is a two-dimensional representation of a three-dimensional problem. So you're doing.
And if you've got a bad X-ray,
yeah, so you
the wrong view, you'll get the wrong information.
Well, you use X-ray as a confirmation tool. You don't use it as a navigation tool. You use your hands and your knowledge of the local anatomy. And if you're not sure, look at models, get a skeleton and feel your way around it and work out exactly where those cuts need to be. And then you'll be able to better orient yourself when you get into the OR.
So looking at our question list, we have questions about MICA, we have questions about MIS lapidus, we have questions about setup and use of different burrs, use of different boxes, RPM settings, OR setup, things like that. I think it may be most helpful for me to first go to, we have a whole set of slides and we didn't know where the questions would take us. I think in summary, really the minimally invasive techniques buy you a better complication profile. I think Alastair hits the nail on the head, but we're still following the same principles. And I think that's important. So say with a bunion, we're still following the same principles, right? And so if we look now at MICA, what are the tools that we use and what are the goals we're trying to achieve? This is sort of a summary of the setup, right? This is what's different now than techniques 20 years ago. One of the questions is, what's the recommended speed for burrs? As slow as it can go. The Promato box will give you 6,000 RPM. Alastair uses a different tool than what a lot of surgeons do, but you want it to be as slow as you can. Cool irrigation reduces your risk for burn, but really at the soft tissue interface, because the irrigation, when you're not taking, so I think there's two different types of irrigation. You have irrigation that's pulsing on the wound, which is helping decrease your wound complication risk locally, but it's not helping reduce your temperature in the bone. And then there's a patient surgeon who removes the burr every so often to irrigate the surgical site itself. How often do you remove the burr? Talk to me about your burr technique.
Well, I like to remember about irrigation, and we did some temperature studies on the Cartiva burr back when. And when you use the Cartiva burr without irrigation, we got temperatures, on an infrared camera up to about 70 or 80 degrees Celsius. As soon as you irrigated, it went down to like 20 to 30 degrees Celsius. So the irrigation is really important. I think if you're starting out and you're worried, just start out with the tourniquet down. The blood will irrigate the bone, and you're not going to get high temperatures. The way you get high temperatures is to use high speed, low torque, and low. You've got to sort of twist the burr into the bone. So I use a fairly high force and pushing it into bone at a fairly low speed. The analogy in woodworking is a router, which is a device that is high torque, slow speed, and literally each time it turns, it takes a little shave of bone off. You got to think every time your burr is going around, it's taking a little shave of bone. And if it's not doing that, it's sometimes because the flutes are blocked. So I'll take the burr out, probably a couple of times a cut, clean the flutes and make sure that I'm not accumulating debris. The other way you can make sure it doesn't accumulate is you can oscillate the burr by your hand, so you can jiggle it in and out, and sort of a trick
Yeah.
David Redfern taught us. And if you jiggle it in and out, then you're going to stop the bone gathering in the flutes, and it's going to stop the flutes getting clogged and then generating heat. So you just got to think, what is the burr actually doing? And if it's not, and it's the same if you're using a drill or a reamer or a saw, it's the same deal. If it gets clogged, it's not going to cut, it's going to create heat. So you got to, anything that's not cutting, you got to look at it and clean it out and make sure that its flutes are all clean. Sometimes you may get a dull burr and you're going to change it. If you're doing a lot of cuts, you might need to change it. So those are my sort of tips on how to keep the temperature down.
My reps always know to have extra burrs, because if it feels dull, in the short term, it feels like a cumbersome amount of time and an expense to swap a burr. The burrs are not that expensive, and you're likely reducing the heat generation and kinetic energy transfer to your osteotomy site, which can give you a non-union. I mean, one of the first cases I did, this is the crux of the difficulty for me for a shared decision-making discussion with a patient. I did a young MIS bunion on a young patient, so their bone's hard, probably didn't irrigate enough. I probably got impatient. I probably didn't clean the flutes enough. It was like my third percutaneous case with a Shannon burr, and she ended up with a non-union. It's my only non-union ever. And so it's one of those things that's burned in my brain. That was 3 years ago. And the patient did fine when we bone grafted her and fixed her, but it required a revision surgery, which is our whole goal, is to reduce revision surgery. You can't be afraid to take the leap, but you've got to be able to be introspective and learn from the mistakes that you do make when you make them. So I think that's the biggest knowledge to impart, is that be patient with it, let the burr work, cool your irrigation, clean the flutes.
You shouldn't be able to hear the burr as well as it cuts. You know, if I hear a burr screeching in a cadaver lab, it's going too fast. You won't hear my burr, you know, it'll literally be just turning, and you should never hear it cutting the bone in your OR. And so I set my settings way down. And if you set your settings way down at the beginning, then you'll get good technique. So this is a high torque, low speed burr, and you got to focus on that. So when you get your box in your OR, set it down to the lowest setting so you can't go fast. And then you got to learn how to lean on the burr, how to use it effectively.
We had a couple questions about OR setup. So mini fluoroscopy unit is, I think, what we both use in most cases. Oh, I didn't mean for that to go forward. So this is the setup. So the fluoroscopy unit comes for a right-handed surgeon, comes from the patient's right, whether you're working on a right or a left foot, because it puts you in the best. This is similar to your setup, isn't it?
It's similar. We actually operate out of procedure rooms, and they're relatively small. So we use nerve blocks and we switch one room to the other. And the setup in the procedure room is that the C-arm will only come in from one side. We've worked.
So you've got to deal with it.
Around it. We work around it. I mean, this is better if you can do it. It's not impossible. You just have to get used to it.
Let's talk about the Mika cut just for a second. So I think working through a keyhole is the best way to describe this. So you want a fairly flat chevron. It's not a true 60-degree chevron. So there are some people who like a true flat cut. The benefit of having a shallower cut is that it still gives you some sagittal plane control for translation, but allows you to fully coronally translate and rotate. Having a steeper cut preserves more lateral cortex for fixation too. Is this a similar angle to what you try to make?
Yeah, it is. And the other problem with a long inferior limb, particularly if you're sort of higher, your green dots high up, and then you go more up the shaft and do sort of what Chris Cote would call a bowed osteotomy.
Yeah.
Sort of somewhere between a chevron and a scarf, is that you won't have as much lateral cortex to get your lateral screw in. The other thing I like to do is I like to derotate the Met head. So if any of you are doing a percutaneous chevron, you've got your cut done, just put a K-wire in the head, and then just look on the C-arm, what it looks like on the head if you simply rotate the head. So if if you correct the pronation by rotating the K-wire up and then increase the pronation by rotating it down, it's amazing how much correction, not only of the pronation you get, but also of the hallux valgus. So I tend to be moderately aggressive at correcting my pronation. But you got to be careful you don't overcorrect it, because you want the nail bed of the patient to end up looking up their tibia. So when they look
Right.
at their feet, they got to make sure they're looking at their nail bed. And you don't want to fail to correct the pronation and leave it so the nail bed is pointing medial. But you equally don't want to overcorrect it and leave it pointing lateral. And so I just saw one lady today overcorrected her pronation. So you want to be careful about that. But if your cut's flatter, still got the chevron, it'll help you, and you should use the chevron early on, because it'll help to control some of your translation, and it'll help to control the plantar displacement of the met head. But you can also get a little bit of rotation out of it. So when you put the K-wire in, you can do the rotation. And then if you're using a solo guide, you can put the solo guide in and then put your K-wire across, and then you've already corrected the pronation before you do the translation. So that's just something about that plane of the cut that will help you.
These, I don't want to gloss over these images. So what you see here is for the osteotomy, you angle your burr. This is making the dorsal limb. And at the same time, you need to translate to stay in the keyhole. So the tip of the burr is rotating. The closer base of the burr is translating. And yet you are also dropping your hand in the opposite direction to keep your burr in the keyhole, so you're not tensioning the keyhole with your burr. That reduces wound complications, keeps you on track. This is something that's, I don't know where else we use this. Subtle.
The other thing that's important here is you've got, look at the hand position. So you got one hand right over the mat head, feeling the bone. Then the dominant hand, you got the finger on the skin, okay? And that creates your pivot point. So you can control that pivot point. And one of the things I notice when folk are less experienced is either their non-dominant hand is not on the bone, or they're trying to pivot the burr without the hand actually being, that finger, that index finger being on the skin to control that. So just a really important point in that picture.
That's how people end up taking more fluoroscopy too. They don't know where they are because they can't feel it, and they don't want their hands in the field of the X-ray, so their hands aren't engaged with the foot. And the more experienced surgeons use less fluoro and more feel, and use the fluoro for confirmation. I think your point earlier was dead on. Let me see. By the way, we do have an active dialogue of QA available on the Zoom, I believe. So if you want to ask a question that we've not addressed with pre-asked questions, just let us know. Let me see. All right, so for how about position on the AP radiograph of where you want the osteotomy for Amika?
Yeah, Joel talks about the and David talk about being on the flare. So if we look at this X-ray here, you can see how the burr is entering on the medial side, just proximal to the flare of the metatarsal head. And that's where you want to be, but you've got to bear in mind that if you want to lengthen the metatarsal, so say you look at your pre-op X-ray and it seems like the first ray is short, then you're going to have to angle that burr so that it exits more distal on the lateral side. And if you do that, you might be getting close to the sesamoid med-head articulation. So in that particular case, you might want your starting point to start a little bit more proximal so that you can gain length and not end up in the sesamoid med-head articulation. So you've got to think about where it's going to come out on the lateral side, as well as where you're starting on the medial side. But
and the opposite is also true. If you're trying to shorten, you need to start as distal as you can to maintain lateral cortical length so that you don't ruin yourself from a fixation standpoint.
Yeah, so they need some thought. And this picture here is an ideal starting point for a standard. If you're not going to lengthen or shorten it, this is correct because it's tilted a little bit distal. So as you go and laterally translate here, you're going to gain a little length, but you're losing 2 millimeters with the burr. So what you lose with the burr, you'll gain again by tilting that a little bit distal. And in the other view, you can see how when you do your chevron, you're going to tilt it so it aims a little bit down. So as you move your head lateral, it's going to plantarflex it a little bit and make up for that 2 millimeter bone loss. Now, if you decide you're going to get more plantarflexion, you've got to angle it more up. And if you feel like the metatarsal head is already plantarflexed, then you may need to drop your hand a little bit down and change to the plane of your chevron cut.
All right, so a little bit about post-op protocol. So here's a patient of mine at 6 weeks, just demonstrates that the soft tissue looks great, minimal swelling. It's a little dorsally translated. He's happy. What are you doing for post-op protocol for these? Are you weight bearing as tolerated from the start? And assuming that the patients, if they're sore through the forefoot, are going to heel weight bear some?
Yeah, so they go in dressings. At the end of the procedure, I use a 4-inch cling. The saline, so 4x4 gauze. Got to be careful you don't make that too tight. Then I see them. I know that folk may see them at 1 week. I don't see them until 2 weeks. And I use a short walker boot. And then I tell them they can weight bear after 48 hours. Again, you're working in a procedure room, and I'm sure for everyone in an ambulatory care center, you think, and you tell them to keep their foot elevated, and then you see them heading out to the car with their foot way down in a wheelchair. And I always worry about bleeding. And so I try and reinforce just that elevation until you can be fairly sure that it's not going to bleed too much more. So I try and say elevate for first 48 hours and then heel weight bearing after that. And by the time you see them at 2 weeks, I stitch them. So I'll take my stitches out at 2 weeks, and then change them into a commercial splint. So I'll use a Velcro splint after the 2-week mark and tell them their activity is tolerated within reason. So rock a sole shoe, work on the range of motion of the MTP joint, get them to do multiple repetitions to get the range of motion back. To wear the Velcro splint, when they're resting and at night, and then and work on increasing their mobility from there.
I think early motion's key. I think elevation and ice are key. What's interesting is that if you have somebody who ignores the range of motion instructions, your outcome is far better than if you had done an open surgery.
Yeah,
because there's no capsular contracture. They essentially end up with normal motion anyways. So it's a little bit lower pressure of an early motion rehab, I think.
Yeah, we haven't really measured range of motion, at least in the perc lapidus, but it is something that is much better than the open procedures.
You don't have any open ones to compare to.
Not anymore.
And I've got some partners. All right, any suggestions for my first Mika? I've used the burr with lumps and bumps for about 6 months. Anything we haven't talked about?
Wait until you're comfortable. The Mika is a more challenging operation, and if you don't, a couple of things about a Mika. One is, we talked about the fact that if you don't quite get it right, you can always bail to open, and bailing Mika to open is not necessarily the easiest thing. I don't know if you have any tips on that, Sam.
I don't. I've never done it.
And you got to get it right. When you've picked the angles and you've cut that, then you're kind of committed. So make sure you get it right on other things first. So lumps and bumps are great to start with. You might find that dorsal chylectomy was sort of lump and bump. That's a good one also to be working on early on. You might find that a chevron, doing a calcaneal osteotomy may be an easier starting point than a Mika. And you can always do the Aitken part.
Yeah.
and do the chevron open. So the Aitken's, a good osteotomy to practice on. It gives you a feel for the burr. It's an easier osteotomy to do with easier trajectory for the screws. And you might even consider some of the lesser toe deformities, because the reality is in a lesser toe, you might plan to do, sort of an oblique cut and preserve a cortex. And if the cortex breaks, well, you treat it like a broken toe, and you essentially buddy splint it with your dressings, and it'll come out fine. So the Mika is really the harder operation. It's the one that everyone talks about, but it's actually technically about the hardest percutaneous surgery you can do.
I have left this, so I think Aitken's, especially if you can find somebody with like a second toe deformity with a little mild hallux valgus that's dominantly an interphalangitis with maybe a subtly incongruent joint, that you can do an Aiken in isolation, where you're really just trying to get the hallux out of the way a little bit. That's a great case too, where you're not having to commit to the chevron, but you can do the lesser toe deformities plus the Aiken. I've intentionally included a lot of the x-rays in this talk that I've included are from my learning curve. Some people hate that term. Recent FAI article about how it's a bad term, but this is a case where for me it was early, and I think if you look at these x-rays, you kind of think I'm digressing a little bit, but if you're doing your first Mika, you want that lateral screw to start very proximal, but you also want it to leave the lateral cortex of the first metatarsal shaft as proximal as possible while still gaining purchase in the head. And what's great about the solo guide, and there are a few questions about the solo guide, is the solo guide puts your K-wire where it needs to go. Now there's a little bit of, it's not 100% accurate like every external jig. It's not absolutely perfect. But if you're learning freehand, it's hard to learn what trajectory you need other than with experience to put the wire in the right place. And really what you're trying to do is maintain the length of the lateral cortical hinge so that your fixation is good and you maintain. So I probably could have preserved a little bit more length of the lateral cortex here.
The critical point when you're doing a chevron Aitken, getting the cut done is, most people can do that. It's like holding the head reduced, holding the pronation corrected, stopping the toe drifting into valgus. So the met head will drift into valgus unless you hold it onto your instrument. So if you're not using a solo guide, you got to do all of those reduction maneuvers and make sure the head doesn't escape, and correct your hallux valgus angle and fire your K-wire all at the same time. The solo guide allows you to break that down into steps. So you can do your, you can correct your pronation like I described, and then get your solo guide in, and then put your wire in, and then have to hold your pronation. And then when you crank on the solo guide, it'll allow you to get your lateral translation. So you do it as a second step. And then you can make sure you got the wire in the right place. So you break it down into its components, and that makes it much easier. And when you get good and you get facile, well, then you can consider going away from the solo guide. But I think the solo guide is a really great instrument to use when you're early on in your training.
Here's a question. The solo device is very powerful. When do you know when to stop? When we start feeling the tightness?
That's a great question. I think
I know it is for you.
You got a question of overdoing it, and I think you can, because it's such a powerful instrument. And I think you need to get it corrected to the point where you're comfortable. You don't want to over tension it, because you may end up with some pain between the first and second metatarsal head. I did have that, although interestingly, the case that you show, Sam, of over compressing it is kind of similar to where I put my percutaneous lapiduses, and I don't get into trouble with those. So it's a good question, and I don't know if we really know the answer of it, because you obviously, when I consent patients, I tell them, well, I could undercorrect or overcorrect it. I wouldn't actually think this is overcorrected, Sam. I would say this is fine.
She's happy. It was one of those where I thought, do I need the Aiken or not? The hallux is still touching the second toe. I'm going to do one. It crunched a little bit more than, I think I got a little bit of a lateral cortical breach here. And then it ends up a little bit more varus than you want x-ray wise, when clinically it's fine. Clinically, that toe is straight though. There is no longer a natural looking bump like we sometimes see. So yes, this is the Mika guide can really push you. I mean, that first metatarsal head's almost touching the second. And this is, you'll see this more with milder deformities. I think getting the tension right is harder with a mild deformity. It almost feels tighter. And oftentimes when it feels tighter, it's because you've cut it in a way that's lengthening you. And the lengthening puts more tension on the whole soft tissue construct of the MTP and makes it feel tighter.
Yeah. Yeah, the one with this one here, Sam, is not so much, I mean, I love where your first head is. You know, you got corrected the pronation, you got it up, you know, fairly close to the second head and stuff. It's almost like the Aiken is the thing that's creating the gap. But if you look at her nail bed, it's pointing straight up, you know, up at tibia, and she's looking straight at the nail bed when she looks down. And so, you know, I think that this is pretty good. I wouldn't be too critical of it.
What size screws are you using? And then we'll go on to Lapidus.
I like the 4mm screws. I use the 4mm screws in both because I find the wire and the smaller one, the 3, is just too bendy.
I agree.
So actually one thing I'll do if I'm not using the Mika guide is I'll make a little pilot hole in the lateral cortex using the 2x12 burr, or you can use the 2x20. But if you penetrate with the burr, you can then bend it and get it sort of pointing in the direction you want to go, and then get your wire in. Because if you think about it, if you're going to penetrate the lateral cortex, sorry, the medial cortex at a steep angle, the wire is either not going to go in, or you're going to have to go in at a steeper angle, and then you're not going to be at the right angle for the other cortex. So one little trick is to make a little pilot hole on the lateral side where you want the wire to go in, drop your hand so it's got the right direction, and then fire your wire through the hole. And so, but I like the larger screw. I just try and put it in every time.
As do I. I've liked it from the beginning, especially if the foot can accommodate it. Occasionally I'll use a 3/0 screw if I don't feel like the residual medial cortex distal to my proximal screw has enough room to accommodate the 4/0, then I'll use a 3/0. But I like the 4/0 too. And I think we have some colleagues who like the 3/0 for the distal screw, and I don't know how much that's habit. I don't think it makes any difference. I like that this is structurally more robust though, and it lets me feel more confident having them put early weight on it. We have a question from Reese Hales. I've got some docs who want to use the 3/0 screw in proximal instead of 4/0. I haven't seen that personally. The reason is your question. Any tips or pearls keeping the 0.9 K wire from skiving? Don't use it. That's my tip.
Well, the skiving thing is all about angle. I mean, you can get any K wire in perpendicular, small or big, but as soon as you start angling it, a small K wire has way less control. And the other thing that can happen too is you get the K wire in and then it bends a bit in the bone because it's off the second cortex, and then you try and drill it and then you break the K wire. And you're more likely to break the small K wire than the big K wire. So there's the smaller screw, while you might think is actually easier to use, is actually harder to use in my book.
I agree.
And so, for sure use it. I wouldn't use it proximally, but if you're in a range where you're 38 or bigger, and you can use a 4mm screw, unless you have to downsize because of your closeness to the edge of bones and things, I would stick to the 4mm screw.
We have another question. Do you ever use just one screw from Mika?
Not me.
Not me. I like the rotational control of the head. I think I think you're hinging a lot on one, because the apex or the tip of the screw is in metaphyseal bone in the head. So the weakest fixation for your proximal screw, assuming that's the screw you would use as one screw, the weakest portion of the fixation is in the head, and that's where you need the most control. So I think you need the second screw. I know that there are surgeons who use one screw very confidently. My nerves can't handle that.
Yeah, I think when you're doing anything percutaneous or arthroscopic, you can't always assume you got your screw in the right spot and that it's got grab everywhere you think it's going to grab. So if I'm doing percutaneous fusions, I will often put in 3 screws because I need 2 screws to get rotational control, and I call my 3rd screw my insurance screw, just in case one of the 2 put in hasn't got bite, because I don't want to see any non-unions. I don't want to see any undercorrections. I want it to heal where I put it. And if I can get 3 screws in there, and then that's what I'll do.
We have 2 more questions for Mika that I hadn't seen previously. How often do you do a lateral release, and why?
I haven't done it in Mika. I mean, traditionally we haven't done lateral releases and chevrons, or most people didn't. I've seen a lot of avascular necrosis of metatarsal heads in my practice. It's a devastating complication. Obviously, when you cut the distal chevron, you're taking away the intraosseous blood supply to that head, and you don't want to lose the extraosseous blood supply. Now, with a percutaneous technique, that's unlikely. But the lateral release, Mickey DeMau has a nice anatomy dissection from Barcelona, and he cuts the ligament between the metatarsal head and the proximal phalanx, sorry, the sesamoid and the proximal phalanx. I think that might cause overcorrection, and I do a lateral release only in my lapidus. I haven't done it in the Chevron Aitkins, but I do think there might be a role for it, because I think that if you've still got that sesamoid held over, releasing the sesamoid to the metatarsal head ligament might be helpful in some more severe deformities. And you can do it in a percutaneous technique, because I don't think you're going to rob the head of its blood supply. Sam, do you do it at all or not?
I find the cases where I have done it, which is just a handful, is when you've got an arthritic MTP joint, it's grade 1, that you're not pushing the indications on, but their symptoms are all medial eminence pain and not joint pain. And so you maybe add a chylectomy with it, and you feel like the joint's just a little stiff. Or I had one case where I lengthened too much, and I felt like because I was lengthening too much, the hallux wasn't coming around as much, so I did one. And I think it helped me a little bit. And in no circumstances, I felt like it was like, I've never felt it's a compensatory thing for a mistake somewhere else, where the metatarsal was too long, or it was undercorrected, or there was arthritis.
Okay. We've got some PROstep lapidus questions, I think. So we
do. That's what's next.
Okay.
Walk us through this case.
Yes. So this is when deformity gets too big for a distal chevron, and I think folk would push the limits until November last year, because there wasn't a percutaneous alternative, and now there is. And so if we look at the picture on the left, we've got 2 problems. One is the severe hallux valgus, regardless of how you're measuring the intermetatarsal angle. But you've also got metatarsus adductus. And so this is a picture of a patient where I've done a percutaneous lapidus. I don't actually have the PROstep lapidus available in Canada yet. We're still waiting for licensing. So I've done it using the cartilage burr, and in this case, the 4mm screws. So I got 3 4mm screws there. And I don't have the shorter 4mm screws, so that's why there's a dart fire screw between the first and second ray. But I elected to correct the metatarsus adductus by using a 2x12 Shannon burr obliquely across the base of the metatarsals there, and then I'll shuck them medial and lateral to make sure that I've opened the bases. And you can see that we've closed down the metatarsals at their bases, and I've used in this case, a compressor distractor, but if you've got a PROstep lapidus kit, you'll have the reduction forceps that you can use for this. And you can see I've put the compressor distractor onto the 4th metatarsal head. One tip here is really important. Make sure you put the lesser metatarsal head pin into the metatarsal head. Don't put it into the shaft, because when you compress those metatarsal heads together, you're going to get a torque on the shaft to head that will break the head off between the shaft and the head. So here what I've done is I've laterally translated 1, 2, and 3 onto 4, and then transfixed them across the bases in the corrected position. And I find that the stability of the percutaneous lapidus, I think, is important. You know, Becky's got some pictures of doing this plus a distal chevron. But I think the correction we need here is way more than a chevron will give you. And that you need to get use the percutaneous lapidus to get your correction. So that's this case. And I like to shuck the osteotomies and make sure I've actually cut through and through. You don't want to do the equivalent of an open internal fixation, you know, an osteotomy without displacement. So you got to make sure that you've actually through and through and you can get your correction, which I do, but just before I put the compressor distractor on.
Do you prep your lapidus first?
Yeah, so I'll follow the routine. So find your first TMT joint, release it, put the clamp on, reduce your pronation, close your arm angle, and then put the distractor on the medial side, distract out your TMT joint, use the cartilage burr, clean out the cartilage. You want to stay take all the cartilage out, but keep the subchondral bone, because your subchondral bone is the strength of your fixation. So we're using full thread, non-variable pitch screws, and that means that you've got grab on the cortex of the metatarsal, grab on the subchondral bone, then across the joint, and then grab on the second surface of subchondral bone on the medial cuneiform, and then into the cuneiform. And we've done biomechanical testing on that, and it's a lot stronger than a dorsal plate and a cross screw. So actually this fixation is extremely robust. I just show this because it shows an approach to metatarsus adductus that, you know, I just didn't have a good answer for before, you know, like 2019 or 2020. I just couldn't think of a way to do it. I don't like to do distal osteotomies because when we move the heads laterally, the tendency in any distal metatarsal osteotomy or head osteotomy is you move the heads laterally, the joint by default goes into a valgus alignment, and the toes will go valgus. So if you do a proximal osteotomy, you prevent that from happening. And if you've got already valgus deformity like this patient had, you can actually release the MTP joints, and then if need be, you know, K-wire them, and you just can't get that control if you're doing distal osteotomy. So I did start off using percutaneous DMMOs, and I didn't like them so much. And then I tried some wiles to get some better control, and they were very stiff. And so I moved to these proximal osteotomies, and I really liked them. So that's kind of a real short summary of my learning experience with metatarsus adductus. But you really need 3 tools in your toolbox for hallux valgus surgery if you're going to do it all percutaneous. You need the distal chevron for the lesser deformity, or if you want to lengthen or shorten the ray. You want the percutaneous lapidus if you've got a hypermobile first ray or a more severe deformity. And you want the percutaneous lapidus with the lesser metatarsal osteotomies for the metatarsus adductus, which, if you don't look out for it, will catch you unawares, and you may end up in a situation that could be really embarrassing. So I actually, if I think I see metatarsus adductus, I just put it on the consent and I say possible basal metatarsal osteotomies, and I make a final decision on the table. Because sometimes if they've got a cavus foot, it's very difficult to project that, particularly if they're then standing on the X-ray plate with slight varus. It may look like metatarsus adductus, and when you're on
it's not.
In the OR, you've got to make sure you got a flat AP of the forefoot, and then that really tells you if they have metatarsus adductus or not. And that's when I make my final decision.
I had one booked last week for make a possible second and third base, and the fellow working with me had come from a service that was predominantly open surgical techniques, and he was like, "Are we doing this? I don't know. We'll see." So I think I have the same attitude. If there's any hint of adductus, you're prepared for it. I like the push it medial first, then bring it back lateral to make sure you're hinged. Tell me about a little bit more about how you maintain that correction.
Well, you can see in this, I've got the compressor distractor from the from the Ortholog Slimline set. And, you know, I put my pins in and then I put them perpendicular to correct the pronation. So, you know, if I think I got 20 degrees of pronation, I'll put both pins in at 20 degrees. So when I correct them, they're then vertical to the plantar aspect of the floor. So I've corrected my pronation. If it's not quite right, I'll change the position of the pin in the first met and change it. I want the nail bed to point towards the tibia. Then I'll close the IM angle and get a picture that looks something like this. And then I will feel the met heads and I'll plantarflex and dorsiflex the first ray until I get it in a position where I think I've got it correctly oriented on the lesser metatarsal heads. So I do the correction in sort of sequentially. So pronation first, close the IM angle second, and then third, correct the plantarflexion. And then once I've got that, I transfix the base of the metatarsal onto the second metatarsal. I didn't do that with my open lapidus, but I started doing that with my percutaneous lapidus because I wasn't sure if I could hold it with the same degree of correction. But it's actually an important step anyway. Because if you don't do that, you can't take the jig off and then fire your screws distal to proximal. So you can't get your screws in until you've taken the jig off. So that's why I get the provisional fixation with that screw. It's with the headed screw like that is the number one reason why I've had to reoperate. There's about a 10% hardware removal in the percutaneous lapidus. So I did see a question about outcomes, and we've just reviewed 140 cases of isolated percutaneous lapidus submitted to AOFAS meeting as an abstract. So it's really new. We had no non-unions in that series of 140. We had immediate weight bearing. And it's to do with the strength of the construct of this screw. We had 5 major reoperations. We had 3 MTP fusions for degenerative change or stiffness. And we had 2 distal chevrons that I did for patients who were undercorrected. And I went back and improved the correction and a 10% hardware removal rate. So, you know, that's, I think, a relatively early series. And so we'll have to see how that sort of pans out for everyone else. But I think, you know, this is, you know, early in the days of the percutaneous lapidus. If we can get results like that, as we get better at it, just like we have with the percutaneous chevron, I think we'll get much more robust results.
We have a question. What's the best way to go about shifting the metatarsal head and getting your screws placed appropriately with slight metatarsal adductus and narrow intermetatarsal space? I think this is a Mika question, but I think it goes to the indications for lapidus versus Mika. Are you more likely to book somebody for lapidus if they have metaadductus, even if it's mild? Or is there a degree of metaadductus where you make that decision that correlates with first TMT instability or severe deformity?
Yeah, I think the first thing you ought to do is know your abilities as a surgeon. If you're more comfortable as a distal chevron surgeon, you know, and you're in a borderline case, we'll do a distal chevron.
Sure.
I'm more comfortable with the percutaneous lapidus. And the second thing you got to know is your patient population. So in our province in Canada, there's no private surgery, you know, so all these cases are done in the public system. And, you know, my, you know, rate of say 80 or 90% lapidus might be exactly the same population as your 20% lapidus. It's just that you've got another, you know, 80% of patients that I won't operate on because they don't have the opportunity. You know, so you got to understand your patient populations too and understand their goals. And so you got to pick the operation that matches their goals. I think of more lapidus if I've got second metatarsalgia. I think of it more if I've got a correct pronation. I find I'm better at correcting it. So there's you know, it's, you know, we used to learn the difference between a chevron and a proximal procedure as a black and white thing. You measure the angle and you do a distal chevron. It's actually, there's a whole bunch of things that come into play. It's your feel of the patient, it's the patient's expectations, it's your ability as a surgeon, it's the, you know, it's how flexible is the soft tissue envelope. You know, can you easily correct that hallux valgus or is it really stiff? So those are the things that I think of in making a decision between a lapidus and a chevron, and don't feel tied to one or the other. You'll learn what's the right decision in your own patient population.
We may be out of time, but
Yeah.
calcaneal osteotomies, quick. This is, to me, the easiest thing to adopt for MIS because it helps you with your cava varus reconstruction cases that you're already doing lateral ligament and perineal work that's probably open. If you need to do a perineal tenodesis or bad perineals in a cava varus and they're grossly unstable, most surgeons are open in that situation. So you already have a large lateral incision. As you can see drawn in this traditional picture here, this is taken from a paper in JFAS by one of the Baltimore groups. The MIS saves you that soft tissue burden. There's Shannon burrs available, 3mm Shannon burrs. This saw blade pictured here is what Guyton and Schoen described using, that's used percutaneously. Is there anything different you're doing technique-wise for a calcaneal osteotomy, especially in a young person where you're worried about duration of needing to burr, bone necrosis, non-union, things like that?
Well, I think if you've got a young patient, you're worried about heat, let the tourniquet down. You can let it down for that segment of the surgery. A good case to start with is if you're going to do a calc osteotomy and then you're going to open the perineal tendons, or you're going to do an open lateral ligament. It's very difficult to choose an incision that either both incisions are far enough apart, or an incision that will allow you to approach both. So that's a great one to start with. And I think that I try and keep my cut relatively anterior. I do a chevron cut, and I always find I start just a little bit posterior, and I check and make sure I'm going to come out. And this is a perfect cut you've got here. I want to make sure I come out in the right plane on the top of the calcaneus, so I'll feel the top and cut towards it with my thumb. And the other thing I'll do is I'll make sure that I'm in the right plane when I hold the leg up. Typically the leg is, patient's leg is internally rotated on the bed, and the temptation is to go across the calcaneus in an oblique plane. You got to make sure you go across it in a transverse plane, because if you say you're lateralizing, you've gone in oblique, you might not be able to lateralize, because as you try and lateralize, you're putting too much tension and you're actually lengthening the osteotomy. So that's an important sort of technical aspect.
Yeah, I like the chevron too. It's hard to do the chevron with that saw blade. If you're using the Shannon burr, it's one of the advantages of using the Shannon burr. I think it's harder to get as much out of a lateral slide, whether it's open or percutaneous, meaning how much translation you can get. And it's hard to do a real three-dimensional translation. You can put in a joker or any other sort of translational device to try to change your varus valgus position of the tuberosity in addition to the slide, but you can't get an open wedge resection osteotomy level of correction as reliably. But in most cases, I would argue you don't need that. This is a case with, I think, plenty of translation for this patient. And then I think the flat feet are the ones that are easier to slide. So this is the opposite direction. This is, to me, I think, better to learn than Mika as a starting point.
Yeah, you're not working against the flexor retinaculum. And so, in fact, if I'm trying to get more correction when I'm going lateral, I'll release the flexor retinaculum on the medial side, which has two benefits. It'll take away the restraint, you get more lateralization. And the other thing is that you're going to decompress the nerve, because sometimes when you lateralize, that flexor retinaculum pulls on the tibial nerve and can give you a tibial nerve palsy.
You doing that open?
I do it open.
Just making sure.
I still know the nerve to do it.
I don't know. Okay. Were we committed to an hour, or what's our?
We are committed to an hour. I know we still have some individuals on. Did we had an opportunity to answer all the questions, I believe, though?
I think at least 80% of them. There were some duplicate questions. There were lots about positioning and protocol and weight bearing and solo guide versus not, and a lot of Mika questions. That's why we spend a lot of time on Mika. But I think the MIS Lapidus, it's so new that a lot of people don't know what questions to ask. The technique you articulated is a technique that is 99% of surgeons don't have that iterative technique in their brain for how to do it, and that's why it's daunting. So anyways,
Well,
not daunting, but
yeah, we can wrap up the call. Obviously, I want to thank both of you for joining. I think this was a great format, including the questions and obviously getting both of your perspectives. And of course, thank you for everybody that took time out of their night to attend. So we appreciate it. The recording will be up soon, and we look forward to seeing you on our next call, which is actually coming up in like 2 weeks on June the 5th. So be on the lookout for that invite as well. Thank you both.
Thank you,
Sure.
Jennifer. Thank you, Sam.
it's easier when neither of us mind talking.
Thank you.
Have a good night, y'all.
Night. Well,